Hello everyone, welcome to my presentation using theory to implement change. Diabetes is an increasingly common chronic disease that affects the body's normal ability to control blood glucose levels due to an impaired use of the hormone insulin. It is estimated that 1 in every 4 adults who are hospitalized also have a diagnosis of diabetes. Diabetic patients face unique challenges in managing their blood glucose due to the physiological stress of acute illness. In 2018, I participated in a workshop presenting a new quality improvement initiative developed by Alberta's Diabetes, Obesity and Nutrition Strategic Clinical Network called Basal Bolus Insulin Therapy, or BBIT, designed to improve inpatient glycemic management for patients with diabetes. In June 2019, our site implemented the provincial BBIT order set, blood glucose, and subcutaneous insulin administration record, along with a new policy for glycemic management. This presentation will address the change issue, the change model for implementing change, barriers to implementation, the identify leadership style, and critical thinking supporting the change. Change issue. BBIT integrates the pharmacology of different insulins to replicate normal physiologic insulin profiles. It aims to anticipate the patient's insulin needs and to decrease both hyperglycemic and hypoglycemic events, minimizing the fluctuations in blood glucose levels, and helps maintain the hospitalized patient's blood glucose within the recommended in-hospital target range of 5 to 10 millimoles per liter. BBIT would replace the subcutaneous sliding scale insulin, or SSI, that we used in the treatment of diabetes in the hospital at that time. SSI did not align with clinical practice guideline recommendation, as the sliding scale regimen was a reactive approach, treating hypoglycemia only after it occurred. It was not individualized to the patient and caused large blood glucose fluctuation throughout the day. These fluctuations made the patient feel unwell and increased morbidity, mortality, and length of stay. Change model. The ADCAR change model supports Best Our Change initiative and includes the following building blocks: awareness, desire, knowledge, ability, and reinforcement. Inpatient glycemic management requires an interdisciplinary team approach. Thus, the new initiative required frequent communication between all team members, including the patients and families, the program manager, the nurse manager, physician, clinical educators, pharmacists, dietitians, nurses, and healthcare aides. Nurses are instrumental in developing, planning, and executing new strategies for the future, therefore are a major influence in the direction of healthcare. The nurse manager brought awareness to the staff about the upcoming change from SSI to BBIT, change necessary to improve inpatient glycemic management. The reasoning behind this change was communicated to all the staff, discussions were held, and questions were answered to facilitate full understanding why the change is needed. The outcome of the desired step is that everyone has the desire to take part in and support the change. To foster desire to make the change as a change champion, I was able to get specific about how using the BBIT order set, insulin, and blood glucose records will change our nursing practice and affect patient care for the better. BBIT eliminated insulin drips from our practice that we use mainly postoperatively, that necessitated extensive blood glucose monitoring, uncomfortable for the patients, time-consuming, with high risk of hypoglycemia and insulin errors. BBIT allows individualized patient treatment as it is calculated according to the patient's total daily dose of insulin used in community, and it can be adjusted daily if necessary, and it is safer as BBIT uses only subcutaneous insulin. The knowledge milestone in the ADCAR model primarily refers to training and education, with the team understanding how the responsibilities, skills, tools, and processes will be impacted. Prior to implementation, we conducted formal and informal training sessions, online access to resources to familiarize ourselves with the new process. Our vision was to get all the nurses to understand the new BBIT regimen, get familiar with the new order set, the blood glucose and subcutaneous insulin administration records, to prepare us how to use this tool effectively. Nursing had a bit of difficulty in adjusting to the new holding insulin requirements, as they were quite different from the previous therapy model. The most beneficial tool was the mock charts that allowed us to practice BBIT in the mock environment, with brainstorming sessions clarifying arising issues from the scenarios, giving us confidence. The first 2 weeks of implementation, we offer job shadowing and mentoring delivered by the unit champions. The ability step is that individuals can demonstrate the desired new skills and behaviors. The final step's outcome is that the new change and new behaviors are reinforced within everyone through taking corrective actions quickly, positive reinforcement, feedback, rewards and recognition, and celebrations. The main reforms needed through the first months after implementation were correction on when and which insulin is held, reinforcement for physicians to use the new BBIT order set, as some physicians deferred to the SSI order due to familiarity, positive feedback and celebration, as overall the implementation was a great success. Barriers to implementation. Change is difficult, and implementing BBIT at our site involved much more than simply releasing an order set for general use. Physician, pharmacists, nurses, and patients' engagement was a key factor influencing the success of the project. The nurse manager met regularly with staff to monitor progress and help with work improvement, and connected with other units to improve organization's performance. As main barriers, we encounter resistance to change, fear of hypoglycemia tolerance, lack of motivation due to familiarity with SSI, and lack of knowledge of protocol. As strategies, our site use multidisciplinary training to address the knowledge gaps, deliver peer-to-peer, review of policy, and making resources readily available. Communication was paramount on our unit. Barriers were overcome through authentic listening, engaging with our collaborators, making everyone feel heard and understand their perspective. Leadership style. My type of leadership is relationship focused and resembles the most with the transformational type of leadership that is based on the idea of empowering others to engage in pursuing a collective purpose by working together to achieve a vision of a preferred future. Our nursing team succeeded together as we trained and learned from each other. I was the leader champion, leading from beside with the help of our clinical educator and nurse manager. Participatory leadership fits my style best as I consider and value the opinions of individuals and communities, their skills, experience, and knowledge, and aims to optimize the collective strength of people. Caring for patients requires a multidisciplinary approach to diabetes management, with various healthcare providers working together, and with patients and families as key team members. Critical thinking. Evidence supports the fact that hospitalized patients with diabetes who experience poor glycemic control are more likely to have a greater length of inpatient stay, high hospitalization costs, preventable complication, elevated incidence of infection, and even increased mortality. Most of the evidence supports basal bolus insulin as the most effective treatment for managing blood glucose and preventing hyperglycemia without increasing the risk of hypoglycemia. Future research that question why sliding scale insulin is still widely prescribed may identify barriers related to ordering basal bolus insulin and assist in decreasing related adverse effects. The initiative was designed to improve patient outcomes by improving glycemic control using BBIT and recommended blood glucose targets supported by guidelines published by Diabetes Canada. A study conducted by DiLuzio et al. Proves the feasibility and superiority of nurse-based basal bolus versus sliding scale treatment in metabolic control and on the risk of adverse effects in surgery patients with hyperglycemia. Conclusion. The purpose of this initiative was to improve patient outcomes by improving glycemic control. This was achieved by implementing a provincial basal bolus insulin therapy, as well by improving communication and understanding of best practice using a multidisciplinary team approach, which includes the patient and their family. Together, we succeeded and accomplished amazing things. Thank you.